right, and our next speaker will be Dr. Christy Duncan, who will be giving an update on the continued efficacy and occurrence of myelodysplastic syndrome in the CALD gene therapy trial.
Thank you so much. I actually am presenting for David Williams, who, stopped me if you've heard this before, has COVID and was unable to attend today. He wanted me to extend his gratitude to ALD Connect for the invitation to present this data today. And maybe before I start, I can just address, as I work at one of the qualified treatment centers at Boston, and we've had conversations with families from Europe and with their providers and are trying to work with individual governments to help secure funding when we can. It's a hard road. It is not an easy road, but we are all, I know at all of the treatment centers, committed to trying to extend the therapy as best we can to different patients. So again, I'm Christy Duncan. I'm the medical director for the gene therapy program at Boston Children's Hospital, which Dr. David Williams founded now 12 years ago. I have been involved with this project since 2012, and I'm happy to present some of the data that we're going to present now, and also some of the data we're going to present is incredibly challenging. As Dr. Prasad said, I'm going to focus a little bit or mostly on myelodysplastic syndrome and what that means, what the diagnosis is, and how we're handling those cases with patients. So a little short. Um, so just to start, we know that it's been a while since we presented new data about the efficacy of gene therapy in cerebral ALD to this community. And so we want to provide an update from data that was uh, aggregated and analyzed in February of this year. I think at prior meetings, we've had data that's been a little bit older. And so just wanting to provide an update about that material. And so what we can see on this slide is the event-free survival. And so this is updated, as I said, from February. And what we can see in this is the probability of event-free survival at 4 years was 82%. And this is in the population of the 67 boys, combining both the ALD 102 study, which was the first study done, and the ALD 104 study. To define that a little bit and dive into it, what we mean by event free survival is these are patients who did not have a major functional disability, which was part of the primary aim of the study, did not get referred for allogeneic transplant for reasons relating to disease progression, either symptomatically or on neuroimaging, or patients who developed myelodysplastic syndrome. And so we can see where that data lands going forward. And it is almost the 10-year anniversary of the first patient treated. So we do have some long-term follow-up, a very long-term follow-up on some of the patients on the ALD 102 study. On this study, we look at the change in the LESS score, so the MRI LESS score over time. And the definition for stability in the studies was that the score remained less than or equal to 9, or there was less than a 6-point increase from the baseline. And so we had the stability of the LESS score in 60 of the 67 patients who were treated. That's 90% of the treatment. Each of the lines, the different colors, represents the MRI LESS score on a different patient. People understandably and always look at that first patient, so the teal color on the far left side. And so this is a patient who was treated very and who progressed very early in the course of therapy. And the next thing, and this is something we've discussed, I think, at this meeting before, but just to bring it back to the attention, is the issue of contrast enhancement on the MRI. Having contrast enhancement on the MRI was a criteria that needed to be fulfilled to be treated or enrolled on both studies. And so we see that when we look at this diagram, I'm going to walk you through it in a moment. All of the patients had contrast enhancement at enrollment and at treatment. And so what we see on this is each of these lines of the swim lanes, each of them represents a different patient. If the color is red or sort of the orangish color, that indicates that there was contrast enhancement at that time studied. The gray means the contrast enhancement was gone. What we hope to see over time is that the contrast enhancement is gone and indicating not active disease. One of the things that we've been trying to understand for a number of years now in this study is this phenomenon where you will see contrast enhancement come and go in different patients. And so we see that at month 6, there were 9% of patients who still had contrast enhancement or had contrast enhancement. At 1 year, there were 19%, and then at 2 years, 9%. And at the most recent follow up, 93% of those patients had contrast enhancement that was gone or resolved. And so we are trying to understand the clinical significance of this data and how and if we should, in clinical setting, react to the positive contrast enhancement. And finally, as for the update on the efficacy, we're looking at the change in the NFS, or the Neurologic Function Scale score. Florian presented this data earlier, and so I won't spend too much time, but just want to dive a little bit more into the granularity of it, because I know that's something that has come up and there have been questions about in the community. So, looking at this, we're looking at on the plot the score of the NFS score on the y axis, so going up, and the time post stem cell infusion or gene therapy infusion on the bottom. And so, looking over time, what we're hoping to see is stability in that NFS score. And stability was defined in the studies as an NFS less than or equal to 4, with less than a 3 point increase from the baseline. And just to level set, all patients you could only have a less score of 0 or 1 to meet eligibility on the study. And so on this, we see that 94% of the patients met that definition for stability of the NFS over time, with 81% of them maintaining a less score of less than 1. One thing that has also come up is the question of seizure. And on this diagram, and we can certainly share it with people individually if it's, I know it's difficult to read. The majority of the patients who did experience seizures, there were 9 of them, and 7 of them did not develop a major functional disability. So trying to determine what that means clinically is obviously up to patients, their families, and their providers, but I think that's important information to know. And so now I want to spend most of this time talking about one of the things that's hardest for all of us who are involved in these studies, and even harder for the patients and their families, and that's myelodysplastic syndrome. Um, so the very first thing I want to do is talk about these 5 individual patients, and then we're going to come back to them again at the end. So just to recognize that as of right now, 5 of the 67 boys who were treated with gene therapy have developed myelodysplasia, and I'm going to talk more about what that is. But that is a type of blood cancer. And these cases, we believe, are directly related not to the chemotherapy, but related to the integration of this product. And we'll talk about that. 4 of the boys were treated on the second study, so that's ALD 104. And one of the boys, this patient here, was treated on the first study. I personally, and I'm not speaking for anyone besides my own opinions on this. I think that that is meaningful. That 4 of the patients on the study that were followed for less or shorter period of time have developed MDS, and only 1 in the first. And we also, one thing that I also believe is notable is that the child in the first study was diagnosed at a time frame very different than the others, so much later. This is a child who was diagnosed 7.5 years after therapy, compared to the others who were diagnosed much earlier. So to understand MDS and to level set, we have to go back to some of the basics of these therapies. And so, first things to talk about are the stem cells. We talk about these all day. I know many of you have seen this from me and from others in the room, but just to make sure that we're all on the same page, we think about blood formation and stem cells. So, the hematopoietic stem cell, right here in the blue, this is sort of the parental cell. This is a cell that can turn into many different kinds, or all the different kinds of the blood cells that come from our marrow. It can turn into platelets, which are those sticky things that stop you from bleeding. It can turn into all of these types of cells, except for these that are part of your immune system. It can turn into red blood cells and many others. In ALD, we focus a lot, and most importantly, on the cells that come from this line, the monocyte, myelocyte, macrophage, excuse me, line, as we think that this part of the lineage is what traverses into the CNS and prevents progression of disease. So this part is important. And just fun fact, so all of us, most of us, are making 100 million blood cells per minute during our entire lifetime. So there's a lot of blood cells being made in this room since we started talking today. So what happens with MDS is something goes wrong at that stem cell line. And so we have all the healthy cells that are generated here. But what we see is that when you have those healthy cells, they divide over a lifetime and they gain mutations. It's similar, mutation is a genetic change. And I know we all know about mutations in this room. And so as those mutations indicated by this cell in orange here get passed along, some of them go away, don't cause a problem. Other of them divide more fast. So divide more rapidly and become basically taking over because they are dividing faster than the other cells in the marrow. And when that develops myelodysplasia or MDS, what we see are a couple of or different possibilities. Sometimes it lays dormant for years. Other times, what you end up seeing is that patients start to drop their counts. So they have lower red blood cell counts, they can become anemic. Patients can drop their platelet counts and need transfusions. You can have changes in your immune function. So your cells drop. And in other cases, for the most devastating, the concerning cases, you develop myelodysplasia. And so that people will argue in the oncology community, is MDS cancer? Is MDS not cancer? Is it precancer? It doesn't really matter. It is treated as cancer. In definitions, we can split hairs about that, but this is a blood forming cancer. And so this has come up, I think, in settings of patients and families in the community. Do these patients, these 5 children that we've talked about, do they have leukemia or blood cancer, or do they have MDS? And I think the way to think about this is along a spectrum. So leukemia often develops from MDS, but what we are talking about with MDS is where you can have some changes in that marrow. So it's really more of a definition rather than, and it impacts how we treat them. So technically, none of those 5 boys met a definition for leukemia. All of those 5 boys met a definition for MDS, but they all need to get treated with stem cell transplants. And so just we don't need to memorize this or go through it, but if you look at this line in the bottom, we see AML is on one side, MDS is on the other, and whether which side of that line you fall on depends on a few things. How if you have sustained or low blood counts, so that's what cytopenias mean, so low blood counts. Do you have certain changes in your marrow? So when we take that little piece of your marrow and look at it under the microscope, what are we seeing? And other things, so increased blasts. Blasts are the leukemia cells. How many of those leukemia type cells are you seeing in the marrow? So that's how we made the definition. And none of us are thinking that MDS is better than leukemia or worse than leukemia. They are different and they are both very serious. So the way that we figure out, or probably the most important way we try and determine whether someone has myelodysplasia or whether someone has leukemia, is to take a needle, put it into the bone marrow, so in the hip at the back, and take a small amount of that marrow out. Marrow, when you take it out, looks like blood that we pull into a tube, and then you take a very small sliver of the bone and we look at it under the microscope. The reason for showing this is not to give a sort of a tutorial on the hematopathology and what our insides of our bone marrows look like, but just to say that it's kind of complicated to look at this and say, is this healthy? Is this not healthy? And so, what the pathologists are looking for is comparing cells like this one, which is a healthy cell. It's got a nice round nucleus. It looks to the pathologist normal, versus a cell like this that has 2 of these lobes of the nucleus where you should have one. That's a little bit bigger and sort of a little wonkier looking. Or this one that's elongated. So when we're trying to do MDS, it's not a test that we send that there's a yes or a no. We have to look at these marrows and grade them and trying to decide what actually is present there. If leukemia is there, though, I will say it looks very different than this. There's a whole, often sheets of the same looking cell that has taken over that marrow. And how do we diagnose this or how do we classify MDS? There are different categories, and this is from a 2016 diagnosis that gives lots of different kinds. So, what we see and which kind it is depends on what you're seeing in that marrow and a patient's peripheral blood counts. The reason that we have these 2 things highlighted are these are the 2 types of MDS that we've seen in the boys on the study. So some of them have had MDS with single lineage dysplasia. What that means is that one of the lines of their blood counts is down. In the case of these patients, it's been the platelet count. So that's something that we're always watching for and watching for very closely. Other boys have excess blasts. In our minds, it means that those boys look like they're heading closer to leukemia, perhaps a little faster, and may need slightly different therapies to the other boys. Um, this slide, we want to present the difference between pediatric and adult patients who have MDS. This is for those of you who are like me, who hear diagnoses, and I'm a physician, but I still look stuff up on Google. And so if you're looking up MDS on Google, you'll find a lot about adults and older adults. And much to my chagrin, older adults in these studies is greater than 40 years old. So the important thing I want to point out here is that MDS is great. It's pretty common, or in the cancer world, in my world, MDS is relatively common in adults. It is very uncommon in children. This is a cancer of adults. The other important thing, and I think the most important thing about this slide, is the intent of our therapy. The intent of therapy for adult patients with myelodysplasia is usually palliation, meaning supportive care, keep you alive as long as we can with the best quality of life we can. That is not the intent with children who have MDS. The The intent for children with MDS is to cure them of their MDS. So, that I think is an incredibly important distinction as we think about these children. This is a remarkably busy slide that is just intended to say that there are lots of choices. And so, if a child is diagnosed with MDS, some of them will go straight to transplant, and some of them will possibly receive chemotherapy before they come in. And the physicians and the people you work with can help to decide whether what is needed and how we get there. So there are algorithms that exist. These algorithms are not designed for boys who got gene therapy because this is a new phenomenon relatively, and that we need to understand how to treat. But one thing just to say is that if you're a child with MDS, all roads lead to stem cell transplant. One of the things that we've been trying to avoid with gene therapy, and this is allogeneic stem cell transplant. And the reason we need to do that is we need to get at that stem cell at the source and get rid of it and stop it from growing and reproducing. So, the heart of the matter, how does gene therapy cause myelodysplasia? Why ALD? There are a lot of companies, lots of academic centers, lots of places studying many diseases for with gene therapy. ALD is one of the few that has myelodysplasia. It is one of the few in the modern era. This was very common 10, 15 years ago in the gene therapy world and far less common now. And also, most importantly, or equally importantly, what are we doing about it? You've seen this, but it is important just again to level set. So you know how we get the cells. The cells are collected by apheresis. We're taking those cells from the marrow. We want them swimming around in the circulating blood so we can collect them. Those cells get collected and taken to a lab. The vector, and in this case, it is HIV that has changed. It is not the HIV that you've heard about that's causing infection or illness, but we modify that HIV because you can harness the good things, if you will, of HIV, and that's really good at getting into genetic material. So we're going to take that part of it, and then you mix it with the gene. So here, just representing the healthy ALD gene. The vector, the virus, carries the gene into the stem cells and it goes into the patient. And if we jump down here, here is our vector carrying that healthy ALD gene. It connects, in this case, to the stem cell of the patient. That gets injected into the patient and over a series of steps and processes gets incorporated into the genetic material of the patient. So in the blue is the chromosomes, the genetic material of the patient, and the red is the gene that we've just inserted. And the reason we use hematopoietic stem cells, well, one of the reasons, is that they continue to divide. So as those cells divide and divide over time, that healthy gene is part of all of the cells that come after it. So we expect this to be a long lasting therapy. So, as I said, the purpose of this vector that's carrying the gene is to insert that healthy ALD gene into the patient's chromosome. One of the main challenges that we're facing is that we can't control where it's put or where it is placed. We know that ALD is a gene that results from mutations on the X chromosome. When that vector puts it in, it doesn't put it necessarily in the X chromosome, it puts it anywhere. It puts it in any of those chromosomes, in any of the places on those chromosomes. And that is really the crux of the problem that we're talking about. And so we talk about, and you heard Dr. Prasad talk about integration site. That means that's the spot where the gene is placed. And it makes all the difference. And you can have thousands of integration sites. And patients do. When we look at the reports, we see patients who have 8,000 different spots that healthy ALD gene was placed. And ALD protein can be made from all of those places. It doesn't have to come from the X chromosome when it's placed there. So that's the good thing. Here comes the challenges, though. So we are intentionally inserting mutation, making mutations. Mutagenesis is not always a bad thing. We are intentionally putting a new piece of genetic material in. So in this case, the orange bar is representing the ALD gene. And these the purple and the blue are the spots where it's inserted. So it can be inserted in different parts of different genes. And when you put something into a gene, you can change what that gene is doing. And so this orange can affect the purple one and make the purple one do nothing different, and that's fine. It can change the function of what that gene is supposed to be doing. It can decrease the amount of work that that gene is supposed to be doing, or it can result in uncontrolled growth of the cells that that gene is supposed to. Insertional oncogenesis compared to mutagenesis, oncogenesis meaning cancer, is when that ALD gene is put near another one that can control the development of cancer. So in these cases, the ALD gene here in orange is put in here. And there are things called oncogenes that, when they're working overtime or turned up, they increase the risk of cancer. There are other genes called tumor suppressor genes that most of the time are working to control the development of cancer in all of us. If we put this ALD gene near a tumor suppressor gene and turn it off, we're going to increase the risk of cancer. If we put it near an oncogene and turn it on, we're going to increase the risk of cancer. So it really depends where you are putting these genes. And we can't control that in this process. So, how does Lenti-D or Elicel or Skysona uh, specifically lead to MDS? It is related in most of the cases to this gene called MECOM that happens to be the name of the gene that we think has caused most of the problems. And so, in here, all this sort of black mix is a whole combination of triangles that are representing the different spots in all of the patients on the studies who have insertional integration site analysis, telling us where in the gene they were put. For three of those boys, right here, and this was before we had mature data on the last two boys, so I apologize for that. We see that they had genes in this part, or the insertions in this particular gene, this MECOM, this cancer encouraging gene, that caused it to grow out of control. What we're trying to figure out, though, is why all these other ones haven't. All those other lines, each of those triangles represents a different spot in different patients. Every boy on the study has integrations in this gene. Not every boy has MDS. We do not expect every boy to have MDS. And so we're trying to understand why some people do and some people. Um, Parts of the reason that we think that this particular product has a higher risk of MDS compared to others is related to how the vector was designed. Each of these things from this review discuss different ways that gene vectors are designed. This one on the top is not, this does not represent the schema of our vector, but it is similar in these other products. And so, what's unique about it in these cases is this thing called an enhancer. An enhancer happens to be an accelerator that drives the expression of this gene. And by that, we mean if you put this enhancer in, it's going to try and rev up production to make the ALD protein. And so, that is in the LNTD vector. It's not necessarily in every other vector that's used in different diseases. So, why did we make that? Why was the vector made that way, knowing that sometimes if you really drive expression, if you put it in the wrong spot or it lands in the wrong spot, it's going to drive expression or the function of those cancer causing genes. And there were a few reasons for that. So the trial was designed about 15 years ago, and we didn't know how much expression was needed to help successfully treat ALD. And we didn't know exactly which cell types were used. So this little blue square here, this is the enhancer that's in the specific vector used in the trials, has been used in others. It's a pretty strong one. It actually drives the expression, meaning the function, of that gene across all sorts of cell lines. And the felt was that this was the appropriate one to try and drive a successful amount of the production of the ALD protein to control disease. So this disease was then, then this was tested, or actually had been tested. So the work that we're talking about today was built on a study that was done in France using four boys who got gene therapy, and they had this same enhancer used. It was felt building on that. There was some proof of safety, albeit small numbers over time. And then there are preclinical tests done. Before anything is put into a human, the product is tested multiple times. And when this particular vector was tested using the mechanisms that the FDA requires, it passed all the safety tests. There was no signal that it was going to contribute to increased risk of cancers. But that also, as we know, there's a difference between what we study in a lab and how people function. And then finally, in another disease, an immune deficiency or immune for children who have a dysfunctional immune system, use this same enhancer, and there's been no expansion and no MDS in that case. So this was not done haphazardly. It was done with most caution as we can, and yet we have still seen this outcome. So what are we doing to monitor? Vinod talked about this for a little bit. We are sending blood tests on boys. For those of you in the room who have children who've been treated, or those who are watching remotely who have children on this treatment, you know that we've changed the frequency of how often we see children and ask for their blood drawn. We monitor their lab tests regularly for changes in the blood counts or changes in the blood cell size. So sometimes you can look at the size of the cells and this gives you a clue. We do something called integration site analysis, which you've just heard about, and I'm going to show a map of in a moment. And we talk to families and patients, and we teach you what to look for. So, does someone have things that are outside your normal? Bruising more easily in places that you don't expect? Are you more tired? Do people look pale? So, all of those things, if they happen, we want to hear from you. I do want to show the slide of an integration analysis. This is not from boys on the study. I didn't want to show people's individual information, but just to show what a map looks like. I'm a visual learner. I know lots of people are, and so this is helpful to me that these things are in color. When we talk about where those 8,000 different spots or 5,000 or however many different spots the gene was placed, we like to map them. So each of the colors on this in this patient shows you the top 10 spots that the gene was placed in this child. So if you have a color that is more, there's more red, as you can see in some of these, that tells you that perhaps that cell, that gene is showing up more often. Maybe that cell is growing more rapidly and can raise concern. So we do these every 4 months now on patients, and we look at, is it changing over time? Is this individual child having different genes in that top 10? Are they showing genes that are concerning? Are they in something called the oncogene, the turning on, turning off cancer genes? And we look to see how they change over time. So is it the same one that's getting bigger? Is it getting smaller? And based on that, make recommendations. So the grid in the back of this study shows you how often in the table that those of us who treat patients look at to see how we're following them. What this highlights is that we follow patients for at least 15 years after a gene therapy product, and that there's set things that we're looking at. So there is a plan for how we're looking for MDS in all of these boys and other complications of gene therapy and the efficacy. And so currently, and this is under FDA guidance, every boy who is treated has blood counts done every 4 months. We're planning to do that for the first 10 years in everyone. We repeat the blood counts if they are abnormal. So, trying really to speak to the families of patients who are treated, blood counts go up and down all the time. If your child has a cold, we are entering that system. Sometimes the white count goes up, sometimes it goes down. Platelets, the one we're looking at specifically, are really finicky blood counts. They change all the time. So, just if you see your provider and your counts are down, it doesn't mean you have MDS. It means that we need to repeat it. We will check. We did integration site analysis at each of those time points. And then we have a very low threshold to do a bone marrow biopsy to go to the source. So I think many people who've been involved in this trial know that the threshold that we do those bone marrows has changed over the past few years in response. And what do we do to treat those boys? We try to find a donor. And so we determine if there is a highly matched related donor, unrelated donor, someone in the registry. Could we do a haploidentical transplant? Could we use an umbilical cord? So we try to find the best donor possible. And then that patient undergoes stem cell transplant. If there is excessive blasts, so more of those leukemia looking cells, we end up giving them chemotherapy and then taking them to bone marrow transplant. So just to come back to the boys that we talked about in the beginning, we have follow up. So for all five of the boys had an allogeneic stem cell transplant. Two of them very recently, so it's difficult to tell you long term outcomes of those patients. And so we had three of those cases in 2021. All of those boys received their stem cell transplant. We had two cases of MDS in 2023, and those two boys have had their stem cell transplant. And you can see the data we have so far in those boys. So the patient on the first trial has MDS resolved. The patient on the second patient listed tragically died from complications of graft versus host disease. And then the other patients, we don't know as much about their long-term case just based on the timing. And what's next? What can we do better? We are trying to test new vector designs in the lab. We're considering new approaches such as gene editing. And just I want to spend one moment on this and then move on. So gene editing, it's sort of the next step. And I think, Dr. Eichler talked about this a little bit more this morning. It is targeted. So we don't have that kind of random placement of genes. What you do is you target the specific gene. So perhaps we're targeting exactly on the X chromosome. You use this thing called a nuclease and it cuts out the DNA material at that certain spot. So targeted removal. And then you can put a new gene in. You can change the gene. You can try an upregulated gene. You can change that specific spot and then use the natural repair process to basically clean that up. And so you zip it up. So this is being explored at different academic centers. We know that there are a couple of biotech companies who are particularly interested, or as Kathleen says, are ALD curious about this, and so we're hoping to see trials for gene editing in the next years. So I think that this is a step that eliminates that randomness of the current process. Um, I'm sure there are a lot of questions. I do want to pause and thank everyone in this room. I want to thank my colleagues, particularly those involved in the trials, and more importantly, to me at least, I want to thank all my patients. I know some of you are watching this remotely. Thank you for trusting us with the care of your children and your families. We do not. Thank you.
Thank you, Dr. Duncan. We will open it up to questions.
Hi, thank you so much. This is Alex Keefe, University of Washington. Um, Great talk. I am curious if you've looked into mRNA technologies similar to what was used for the COVID vaccine. I know that in a lot of metabolic conditions, they're now opening up clinical trials such as OTC deficiency. And I saw there's a phase 1/2 trial also for cystic fibrosis. Is this another area that you're exploring given the safety and that you don't have to then worry about integration into the DNA?
Yeah, I think it's a great question. I don't know of sites that are doing that yet, but it would, I think, be a very, it's a very appealing process to use that, to use some of the things we've talked about with not the ex vivo gene therapy, but the in vivo when you're putting it right at the source, gene editing, and more of the specifics. So I think all of the other arenas within gene therapy are out there, and I think ALD is actually a very good target for most of those therapies. I just don't know of anyone doing mRNA just yet. We'd love to know if others do. Katie.
Thank you, Dr. Duncan. That was excellent. I just had one question. I saw on the one slide that unfortunately the one boy had passed away from graft versus host. And I'm just wondering, is the risk of graft versus host any different when you're treating with a transplant for a cancer like this versus when you're treating for ALD?
Yeah, it's a good question. So the risk for graft versus host disease is primarily due to the degree of match. And so if you had, so when we're talking about the match, we're talking about matching at the immune system because we want to try to convince that new immune system coming in that it should be there and not that it should try to attack your body the way it would try to attack a virus and infection. And so when it does not match very well, or there are other triggers or other things, that causes graft versus host disease. So in most cases, it's less about why they're getting treated and more about that degree of match. And then beyond just the match, the age of the donor and other things. There is, though, some question about whether, so for patients who have cancers who've had chemotherapy before, received a lot of chemotherapy, is there damage to certain organs, to different cells that may put you at higher risk for that? It's possible. In patients who have second transplants, second allogeneic transplants, we see higher risk of graft versus host disease. But the allo after auto um, is not very commonly done, and so we don't have great data about that. And actually, I don't know. I don't have a lot of details about that particular question.
Any other questions?
Oh, sorry, Katie, go ahead.
Follow up.
They're usually right. So for that other case, it's mostly two separate allos for someone who had cancer and then their cancer relapses and then they have another transplant. So those patients come into transplant very heavily pretreated and having received very strong chemotherapy more than once. And oftentimes you change donors. So now you're talking about multiple different immune systems in the mix, which is probably part of that issue. Um, in this case, we're talking about two immune systems, which is very similar to what you started with your allo in the first place. So what we don't know because of small numbers is the risk of graft versus host disease if you have an allo transplant after gene therapy. Is that greater than it would have been if you had an allo in the first place? We just don't.
Any other questions?
So two questions. Originally, there was one patient that got the MDS from the original vector, and then you had four from the second vector. What were the number of patients getting each of them? Like, what were the percentages of people that got that. And as a follow-up, when you're talking about putting the repaired gene in a safe landing zone,
Yeah.
are you talking about like technology similar to CRISPR? And is that like something you can incorporate with what you have?
Yep. Maybe I'll answer that one first. So CRISPR is actually gene editing, and there's just different ways you do gene editing. CRISPR is the name of that enzyme that chomps out, that goes to the specific spot, finds it, makes the cut, and goes there. So there's CRISPR's gene editing, and that's what we're talking about. And whether it's that specific brand of gene editing or there are different types that people use. So yes, so that's what we're talking about. And I think one of the nice things about gene editing too is that we know that genes don't live sort of in a silo. They are influenced by the location that they are in. And it is very appealing if you can put the ALD gene in the X chromosome, it may be influenced by the environment. And so that may affect outcomes. So we don't know that for sure, but it makes a lot of sense when you think about gene therapies and putting something in the appropriate location. And then for the first question, they all received the same vector. The primary, so between the first study and the second study. The difference in the boy in the first one, there was two, probably the biggest difference. There are small differences throughout it. The first study used a different chemotherapy conditioning regimen than the second. The first study used two very strong drugs. We call them alkylator chemotherapies called busulfan and cyclophosphamide. Almost every gene therapy study in the world for every disease uses busulfan. Cyclophosphamide was added, which is also very strong, to that first study based on the work that had been done in Paris, and also based on the desire to make sure we don't fail getting these cells in there. Time is too important in ALD for us to have graft failure where the cells don't grow. And so that's why that was done in the first trial. After that study, and so it's a little more than half of patients were on the first study. And then you compare that to the second one, the dose intensity of the conditioning was decreased. And that was done, there was a larger meeting of investigators, of Bluebird, of lots of people in the community to think about what should we do next. And so busulfan was still used, because that's sort of our backbone, if you will. And then fludarabine, which is a different chemotherapy agent, was used. The reason that was done is that's how the allo world, in many cases for ALD, had moved to using that. It's a less intense regimen. So we're hoping to have fewer long-term side effects of treatment using that. So that was the second case. And so we don't know. Obviously, these are still small numbers, 4 and 1, to really do any sort of statistical analysis. And we all approach this, and I imagine different investigators in different sites and different investigators at the same site look at this and think trying to decide whether the conditioning regimen is the difference or not. I think there's something to it personally. And so trying to figure out scientifically why using a less intense regimen would put you at a higher risk of MDS or cancer is something that we're actively trying to understand.
What were the percentages, though,
Percentages of the patients
from the original to the second?
So the first trial, I have to do some fast math because I don't think I have this. The first 3% and 11%. Katie did the math for me. Perfect. Thanks. Thank you. Division should be easier to do on the fly than it is. Thank you.
Thank you so much, Dr. Duncan.
pleasure.
Round of applause. Really appreciate that.